with clinical presentations of various fungal infections. So, yeah. So the cutaneous and subcutaneous mycosis, these are very, very common in contrast to the systemic mycosis, which are less common, and like they are mostly in some with some compromise, mostly immunocompromised patients. But these infections are very, very common. And my focus, and because of the time restrictions, my focus will be mostly on the clinical part only, how they look like or how to recognize, when to suspect that we are dealing with mycosis in the skin or just in the subcutaneous tissue. So we will start. So in the superficial ones, tinea, candidiasis, pityriasis versicolor, and Piedra. These are the most common ones. And especially in the last few years, maybe around 5 to 7 years, tinea is very, very common infection across multiple countries, and even India. It can be called as like a recent surge in the difficult to treat tinea infection. So this is very, very common infection. Other infections like deep mycosis, they can be divided into subcutaneous and systemic mycosis. So there are various predisposing factors, and then there are various pathogenesis factors. I'm just not going into detail because of the lack of time. But mostly in general, we can say that there is some role of neutrophils and some role of T-mediated immunity, T-cell mediated immunity. So tinea, also called as dermatophytosis, in which fungi invade and multiply in the keratinized tissue. So keratinized tissue means basically the cells which have been mostly turned into keratin. So this happens in the usually in the topmost layer of the epidermis, where the cells are slowly decreasing their metabolic functions and their life, and they are almost about dead. They are not fully dead, but they are almost in the process of a systematized type of slow death before they are shed of skin. So they are called as keratinized. These infections are caused by either trichophyton or epidermophyton or microsporum species, and the most common include tinea rubrum. But nowadays, recently, there is a like little turn. So we are also seeing mentagrophyte, even more common sometimes. Like in the AIIMS study last year, we found mentagrophyte more commonly than rubrum in the skin. And this is the classic presentation. One can see that there is typical annular lesion. Annular means the inflammation or the activity of the diseases at the periphery. And the center is almost clear. It's not fully clear, but almost clear. So this is the hallmark. That's why it was previously called as ringworm infection. And this infection means that the margin is advancing in all directions. So slowly, the more and more keratinized cells are getting involved with this infection, and the disease is progressing outwardly on the periphery. We can also see some pustulations here and there, some tiny pustulations. So that means probably, in fact, inflammation is intense enough, and maybe probably this particular in this particular patient, probably the infection might be related to the some species which are not fully human. Similarly, tinea pedis, so we can see here also, we can point out that although there is this lot of involvement on the dorsum of the foot, but still there is a clear-cut margin with some scaling and elevation. So this is also, again, we can see a clear-cut border that is very, very suggestive of tinea type of infections. It helps in differentiating us from other diseases. And here what we can see, multiple rings. So this is also now common, especially because of misuse of topical steroids, misuse of systemic steroids. And then again, we can see the same presentation with other things which are denoting that probably there are some also other side effects of various forms of steroid abused. Because actually steroids gives immediate relief in the inflammation, so it is often prescribed over the counter. It is taken over the counter. It's taken by the patient themselves without consulting anyone, and often they think it is improving, but actually it is not improving. It is just hiding. Because of steroid misuse, the tinea hides the skin. We can see a nice, not nice, but gross stria on both the bilateral thighs because of, again, probably hypopigmentation, also because of steroid abuse. And this is, So steroids can mask actually the original image of whatever we should expect in the tinea. Nail infection, tinea angum we call it, and it's also very, very common. So the most common variety is this, where we are seeing involvement of the distal and lateral parts, which starts from the one side of the nail plate and involves. We can see discoloration, white and yellow discoloration, and also we can see this collection of some debris just beneath the nail plate. This is very typical presentation of tinea. So this debris, if we take it out, we can easily demonstrate hyphae and spores in this. Tinea capitis, non-inflammatory variety, we can see multiple black dots. That means the infection has invaded the hair shafts and has led to almost like cutting off at that particular point where the hair shaft becomes weak, and this leads to this presentation of black dot variety. But one can also commonly see, especially in the children, one can see the inflammatory variety, which is also called as therion, where we see lots of inflammation, so lot of pus collection, erythema, and definitely hair loss, scarring type of alopecia is also there. And most of the time, this is confused with the bacterial infection, acute pyoderma. So it is often late diagnosed by especially by those people who are not acquainted with this diagnosis. So it is often treated with multiple antibiotics, but to no avail, no response. And this is like very common in children. Again, we can see this is also tinea, but again, the problem is repeated application, long-term application of topical steroids. So it can, like one can then confuse whether it is because it's not showing the typical lesions of typical border annularity. So, but still it is tinea, but a heaped up sort of presentation. So this type of presentation can also happen with the steroid abuse again. And sometimes we can see that just signs of inflammation are totally masked, and this is more like looking like a Hansen's disease, hypopigmented annular plaque, but actually it is tinea only. So basically, my message is that whenever we are even little suspecting, there is no harm in doing a small investigation in bedside QH, like easily available and easily can be done. So that must be done in all the patients wherever we are suspecting even little, even remotely tinea infection. Similarly, here we are not seeing scaling, but non-scaly lesions can also fit into tinea. This is slightly atypical, but still it's possible. So this was again proved to be tinea infection. And diagnosis is easy, almost about 80 to 100% QH mount sensitivity. And only thing in the nail and here you have to wait a little for the keratin to be dissolved before we see this light. The next common one is Piedra. This is very, very common infection, common in general population. So it can cause seborrheic dermatitis. It can aggravate seborrheic dermatitis actually. It can cause the typical presentation of pityriasis versicolor, as well as it can sometimes cause pustules and folliculitis. So we will see how it look like. So this is the presentation. Versicolor. Pityriasis word means scaly actually. So wherever we find scaling in dermatology, it's often termed as pityriasis, and versicolor means different colors, multiple colors. So either in the same patient or in different patients, you can have multiple colors. So here we are seeing various shades of brown color in the left side, and the hypopigmented, almost macules. They are not actually plaques. They are just like in the surface, and there is very subtle scaling, very almost like powder. So powdery scales with this type of discrete to confluent type of macules with fine powdery scales, that is very suggestive of pityriasis versicolor. And the good thing is that it responds to the traditional antifungal agents also, like fluconazole. So nowadays we are facing more and more problems in treating tinea, but not in pityriasis versicolor. It still responds to the various agents. And there are atypical presentations like very extensive lesions. Then there are various thick plaques. This is heaped up crusted lesions on the areolae and nipple. And then there is a condition called as confluent reticulate papillomatosis. So these all presentations are possible with partial or full role of pityriasis versicolor in them. So sometimes we commonly see tinea, we commonly see acne vulgaris on face and trunk. both the sites are very common for but if we are finding multiple pustules, then definitely we give a thought that are we dealing with fungal folliculitis, Pityrosporum folliculitis, and it sometimes comes out if it is KOH positive, then it can be nicely treated with simple antifungals, because otherwise the treatment course of acne is very, very different. So this was easy to see in yeast KOH. And then candidiasis. Candidiasis again is like superficial type of infection in the commonly in the mucosa. Sometimes it comes onto the skin and nails, but mostly it is in the mucosa, or it can invade inside also, especially in the immunocompromised patients. So like these are the various common presentations of tinea. We can see the oral thrush, cheilitis. So lip involvement is also there, angular cheilitis especially. And the neonates can have involvement of the near the genitalia, especially the like occluded areas, diaper areas, those areas can be commonly involved. Then scrotal dermatitis, and even between the webs. So this wherever basically the candida wants moisture. So either in the mucosa or in the skin, if there is lot of moisture, lot of maceration, then candida finds it easy to invade. So that is the preference of candidal infections. Then these are not very common. Tinea nigra, just brownish macules present asymptomatic without any itching. They are present on the palmar and volar like plantar surfaces. Then again, black Piedra. This looks like as if some blackish collection on in a like a shell form on the shaft of the hair. And then there is white Piedra also. It again looks like just white dots, is often confused with pediculosis, means lice infestation. But if you carefully see, this is like different. And in the microscope, we do not find any lice. So this is like a shell-like covering on the shaft of the hair, called as white Piedra, caused by Trichosporon species. So I'm not at all going into any detail or any treatment investigation, just because I have to cover in 20 minutes every basic, the most common clinical presentation of superficial mycosis. Now moving on to subcutaneous varieties of mycosis. So there are varieties which are mostly caused by implantation, either a thorn break or some invasion or some unnoticed cut, and then the fungi invade into the subcutaneous tissue. Those include eumycetoma, because eumycetoma means true mycetoma. So there is another variety of mycetoma which is called as actinomycotic mycetoma, which is not caused by fungi and responds to antibiotics. While this variety is caused by fungi and called a eumycetoma. Then chromoblastomycosis, not very common, but still seen sometimes, especially in the referral centers like our institute. Implantation, pseudohypomycosis. Sporotrichosis, you will see very typical presentations of these. Entomophthalmycosis, which is also called as subcutaneous zygomycosis. And then lobomycosis, which looks like more like keloids. Okay, and also it's the distinction between these is are not very, very strict. So sometimes it can happen depending upon the immunity of the patient. Same organism can cause either chromoblastomycosis or pseudohypomycosis. So there is some like in the development of clinical lesions, there is some role of immunity also. And then this spectrum is described as the same organism can cause various types of presentation depending upon the patient's immunity, especially if there is involvement of the melanized fungi. Okay, so coming to the very common one for us, for India, it is very important to know about the agents and the presentation of eumycetoma. Basically, in all the mycetomas, the basic thing is indurated swelling. We will see image rather than this. Okay, so indurated, almost like firm to hard. Swelling commonly on the acral areas, but can also be. We have seen a very, very large presentation of mycetoma on the prox shoulder also, but one mostly finds it on the feet. So indurated swelling, multiple discharging sinuses. Their sinuses are there, they are multiple, and what they discharge is colored material or grain. Sometimes it is just white, it's sometimes yellow and black, and then there are species which produce these specific type of colored grains. So this is a triad that indurated swellings, multiple sinuses, and these type of specific grains which are very, very suggestive of mycetoma. Even if in the biopsy or in the culture we are not able to demonstrate the particular organism, if we just see the clinical presentation, one can easily diagnose at least mycetoma, and then further one has to work up whether it is caused by actinomycotic mycetoma or because of fungus. So that we have to differentiate later. But the clinical presentation is very, very typical that one cannot miss actually the diagnosis of mycetoma. And then there are various complications also possible, especially the bone involvement, especially the cases because they are often late diagnosed and untreated. So they can involve tendons, lymphatics, and lymph nodes and bones and everything. So this is the like chart. Just I'm not going into detail, but basically the total focus is on finding the organism. Whether in the if one can find a grain, then that that is lucky point. But if even if we don't find grain, we look for any collection of neutrophils in the biopsy, and there we look for the organism. Okay, then various types of grains are described, like in black Madurella mycetomatis is the most common cause, or Leptospira black again, and white to pale yellow in Pseudoscheria, and Acrimonium white to yellow again. So basically, this is just a hint, and then we have to confirm with the in the biopsy as well as in the culture. These are the actually microscopic views of the grains, and here we see that there is this collection of pinkish material around the grain. You can see just at the periphery. This is caused by our like collection of immunoglobulins. So it's also very typical Splendor-Oakley phenomenon in certain grains. Various agents are given for eumycetoma. If we can demonstrate fungal elements, then we give. And mostly tetraconazole is given. It's not that costly as compared to voriconazole, although voriconazole is very, very effective in various case reports. But in general, eumycetoma is not that easy to treat. Sometimes it may happen that patients are responding initially, but cure is not easy. And sometimes we have to resort to even surgery, surgical assistance also. So relapse is also possible. And yeah, we have to again coming to the chromoblastomycosis, which is also very typical presentation is there of chromoblastomycosis, again caused by melanized fungi, and it's typically known by those presentation of muriform cells. One if one finds it's almost diagnostic, and that's what we see clinically. So we can see initially we can see just erythematous plaque, and then it grows into some verrucous presentation. So that verrucous presentations can be nodular or may look like a tumor, or sometimes just flat verrucous. But what is more typical of chromoblastomycosis is presence of these dark points or dark like individual uh, collections. These are very much they give very much raise suspicion of we are dealing with the chromoblastomycosis. Otherwise, similar inflammation we see in cutaneous tuberculosis also. Similar inflammation one can see in even Hansen's also if it is in chronic type 1 reaction. So here what is very, very helpful in diagnosis is presence of this tiny pigmented points. These are very suggestive of chromoblastomycosis. Okay, again, I think it's best visible in this particular maze. We can see one tiny okay, then the various presentations you can see that even scarring it can cause, lot of scarring it can cause. Okay, definitely complications are possible if untreated, so it can lead to chronic lymphedema and secondary infections. Even squamous cell carcinoma can develop in the lesions, and then various differential. This in general, deep fungal infections have various differentials just simply because they are deep. So when whatever is very superficial, we have more clinical signs, and whatever is deep, we have less and less clues, and many of the diseases behave in the same clinical morphology. So like here, we can see verrucous tuberculosis. This is actually hypertrophic variety of lupus vulgaris, and it is looking almost like what we are seeing in other lesions. So there are various differences, including so we have to confirm before we start treatment. Okay. And we do KVH, we expect neuriform cells there, and definitely subjected to histopathology as well as here again, sometimes it responds to antifungal treatment. Sometimes we have to do some destructive measure also, like carbon dioxide laser, some cryotherapy, heat therapy, all those things. Itraconazole, again, azole are the main agents, but here even terbinafine can help. Okay. Next is pseudohypomycosis, again quite rare. It's again caused by melanized fungi, and most common agents include Exophiala and Mangiella. And yeah, it's again the most common presentation is typical presentation is subcutaneous cyst. So it is more like a cystic swelling which presents on the skin, and we find that if it is caused by fungus, then it is most commonly pseudohypomycosis. And this is the most typical presentation. One can see very indolent type of swelling, not much of inflammation, just some slowly growing type of cystic swelling. That's what we suspect in hypomycosis. But there are various, a range of clinical variants are there, including a non-healing ulcer, and sometimes even just scaly erythematous plaque. So those type of atypical presentations are also there even in pseudohypomycosis. One can confirm it on various culture media as SDA. And these are how these pigmented yeasts and pseudohyphae are seen in the pseudohypomycosis. And again, the treatment is mostly azoles, itraconazole, voriconazole, and sometimes other agents are also. The next very typical presentation is sporotrichosis. It's also called as gardener's disease. It's basically, it's usually caused by some prick of thorn or some wooden material. It's also one of the implantation dermatosis caused by sporothrix chancri. And yeah, mostly it is localized, like mostly it is localized to skin, and then rarely it invades inside in the bones or in sometimes in the system. So there are two types most common. This is the very typical classic presentation of Cutaneous sporotrichosis, where what we are seeing is multiple nodules arranged in a linear fashion. So much so, actually, sporotrichosis is mostly seen in this fashion only, that there are skipped areas, and then the nodules are almost jumping up and up and up, and finally they are progressing along the lymphatics. So it is so much classic presentation that whenever we see other dermatosis presenting in this fashion, we call it a sporotrichoid pattern. So this sporotrichosis is very typically known by its linear lymphatic spread with skipped areas. So this is quite typical of sporotrichosis, very typical. But then other varieties also, there are fixed cutaneous sporotrichosis, and then there is also this disseminated variety of sporotrichosis. So these are rare, not very common. The most common, again, we have to remember is this linear lymphatic spread. So yeah, then there are various other presentations. Here, what we expect in examination is asteroid bodies, asteroid star-like bodies. One is seen, one is there visible on the right upper corner. So that is very typical. But again, if we can prove it with culture, then it will be definitely a definite diagnosis of a sporotrichosis. If luckily it responds mostly to itraconazole, and we need not. Sometimes we add saturated solution of potassium iodide also, but mostly it responds to itraconazole. Sometimes we give other agents in the resistance cases, or even in disseminated sporotrichosis, what we observed that itraconazole can give a complete cure also, but it has to be taken for sufficient length of time, maybe 6 months or more. Okay, then zygomycosis. So zygomycosis, I will just touch upon, because there are other varieties also, but in skin also, in the superficial plane or maybe in the subcutaneous plane also, we are seeing zygomycosis. So what we call subcutaneous zygomycosis is just two varieties, entomophthalmycosis and also basidiobulomycosis. So these are zygomycosis for our subcutaneous part. Then there are systemic zygomycosis also. I am not touching those, not 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 discuss those. This is very typical presentation. Here we are, what we are seeing in this image is the indurated swelling of the upper part of the face. And how do we diagnose? What we want to look into this. Just two things, simply two things. See, first thing, simply because it is starting from some nasal sinus, paranasal sinus, so it has to be located or connected to the nearby sinus. And second thing, you often find history of nasal blockage. Just try nasal blockage because the progressive involvement of that nasal cavity also. And the most important thing what we look for is it is very hard. It is woody hard. It's typically described as woody hard induration of the plaque. So whenever we find woody hard induration, we immediately try to palpate it. And what we want to palpate is if we want to go beneath the plaque by our fingers or not. If we are finding a very clear margin and then we are able to insert, not insert, we on the skin only if we want to like just feel the inner aspect of the plaque by that palpation, it's very, very suggestive that we are dealing with subcutaneous zygomycosis. Often it is asymptomatic, but it is quite slowly progressive. But here we found one atypical presentation of this subcutaneous zygomycosis. And he also responded to treatment with proper antifungals and then was cured. Okay, so this is, yeah, in the basidiobulomycosis, often it occurs in children, and the other variety what we saw is entomophthalmycosis is seen in adults, and the typically it's present on the upper back. So the shoulder region and just below the neck, upper back region, that is very, very like common region for basidiobulous variety of zygomycosis. While here what we saw was like involvement of the central facial regions. That is more typical of this type of conidobulous variety. Treatment is almost same. Here we add azoles and also often we add saturated solution of potassium iodide. So basically the like rule thumb of rule is that rule of thumb is that we whenever we suspect that this subcutaneous fungal infection is probably not going to invade in the vessels, there we can safely add saturated solution of potassium iodide. Otherwise, we just limit ourselves to the azoles. Okay. Another very rare variety, especially in India, it's very, very rare, lobomycosis, and caused by Locasia loboi, and it's also called as keloidal blastomycosis. And here, what we see is keloid. Basically, keloids are just very firm or almost hard uh, subcutaneous nodules which come and then they are very, very, very persistent. They are not easy to treat by any method. So this is the similar presentation we expect in lobomycosis. Okay. Then rarely what we see that systemic mycosis can also present in skin lesions. So they will not, those patients might not have systemic features and they just only the seeing the skin, we suspect that probably there is disseminated infection. So that is also possible. Like this, oh, this is a different case where we saw just aspergillosis with fungating ulcer, large non-healing ulcer, and he had no immunocompromised. We worked him up for in detail and just found to have localized primary cutaneous aspergillosis. And then these lesions, which are more like what typically we see in molluscum. Molluscum is basically uh, discrete whitish papules with sometimes erythema and sometimes central umbilications. So that is typically described in molluscum. But it can be there that if we find a little more inflammation that usual molluscum, then we start suspecting are we dealing with something else. And here the diagnosis paniciliosis also for this. Talaromycosis, and this is often seen in HIV patients. It's one of the conditions which can occur in, especially in the northeastern part of the India. It's seen in the immunocompromised patients, in the injectable drug users. So thank you. Also have like other slides, but I think I don't know whether I have that much time allowed or not.
Sir, you have time, enough time, you can proceed.
So this is more like just touching upon the typical presentation of systemic mycosis in skin. So this is basically these internal infections or systemic infections will be dealt by Dr. Sagar in the next presentation. But I will just touch upon the typical skin lesions because that is also very important to diagnose. Sometimes the patient presents just with skin lesions, and anyway, skin is very approachable area, so one can easily take biopsy and send various cultures and smears. So that's why I will just touch the cutaneous parts. So histoplasmosis, also called as Darling's disease, it's one of the diseases caused by dimorphic fungi, Histoplasma capsulatum. And there are various risk factors like immunosuppression. Various varieties are there, like subclinical disease, acute pulmonary type presentation, then just hypersensitivity reactions like what we described as erythema nodosum or erythema multiforme, means infection is there elsewhere, but in the skin there are various subcutaneous nodules which will definitely not yield any fungus, but they are there as reaction of this histoplasmosis. Then sancriform ulcers, so they are also common. But what commonly or typically we see a disseminated variety of histoplasmosis is molluscum like papules and sometimes nodules, sometimes also deep ulcers with heaped up borders. This is the typical presentation of disseminated type of histoplasmosis. So the clue is here is like when it is disseminated in the system, it's also disseminated in the skin also. So we often suspect whenever we see such type of presentation on the skin, we definitely take that patient very seriously because that patient should have involvement. This can disseminate only through blood. So what we do is full investigation to check every organ whether they are also involving lungs or maybe sometimes other areas, other even brain. And what we typically see is just we have to find the typical inside the macrophages, we find the fungi which is there. And various methods including histopathology, peripheral smear used, and then there are nowadays antigen detect and PCR, everything is there. So I think that part will be covered by Dr. Sagar better. And here the treatment is more aggressive. So we go for liposomal amphotericin B. They are not responsive usually to traditional agents like terbinafine or proconazole. Cryptococcosis, again, this is look like more like round nodules, large nodules, small to large nodules, and they are also again very typical, very look like almost similar to molluscum contagiosum. They are whitish nodules of various size and typically present in immunocompromised patients only. Rarely you will find that cryptococcosis is there. But that again, there is some form of immunosuppression, maybe selective immunosuppression or old age or diabetic is there. So otherwise, it's mostly limited to the severely immunocompromised patients. And here you can see in India in preparation, you can see these capsulated, thick capsule is there around that yeast. One can see that in the histopathology also by various stains. Here we treat with fluconazole as well as amphotericin B plus flucytosine. So it's again very a life-threatening type of disease, and again can involve meninges and it can cause various complications. So it has to be treated as very aggressively. Aspergillosis, again, I am not going to just we will see one presentation in skin. So it looks like large ulcerated lesions. Basically, what we do, whenever we see such presentation with chronic inflammation, acute to chronic inflammation. And when we have ruled out pyodermas and our autoimmune diseases like pyoderma gangrene or some, then we start thinking of these deep fungal infection, including aspergillosis also. So again, systemic zygomycosis is also there, and mucormycosis. Again, many of us have seen lots of mucor in last few months because of the post-COVID complications, and we have better experience of this in this year. Again, it requires liposomal amphotericin B, and then there are newer agents also. I think Dr. Sagar will cover those. Systemic candidiasis can also present onto skin. So systemic candidiasis is there with this predisposing factor, whatever, multiple immunocompromised situations. And what we see in skin is tiny pustules disseminated all over the body. So this should not see in the differentials of this type of exantheme, which is pustular exantheme, one can keep systemic candidiasis also. Otherwise, it's commonly not given importance, and other differentials like drug-induced rash and this and that are also kept. So systemic candidiasis can also present as generalized pustular lesions on skin. Okay. And blastomycosis, again, very, very rare, I think, very rare. This ulcerated plaque with lot of crusting, lot of surface changes, blastomycosis. Coccidioidomycosis and paracoccidioidomycosis. I think these are very, very rare in Indian setup, so I am not going into much detail of these. These are just to know that these exist, and sometimes we have to keep differentials because of the rarity. We don't take them very seriously. Penicilliosis, we had seen one case, one image earlier also, and this is the typical presentation. We often it is very opportunistic in HIV positive patients who's especially injectable drug users. There in the Assam and Manipur, it is the third commonest opportunistic infection, and also nowadays called as Stellaromycosis. And again requires amphotericin. It's a quite aggressive type of fungus. We have to treat it aggressively. Pythiosis, it's not again very common, but just causes ascending gangrene of upper limb or lower limb. So it is difficult to treat condition, one of the few conditions. Thank you.